I used to do corneal inlays, and many of the surgeons, they think that corneal inlays is not a good one, and patient satisfaction was not so good. And I thought that this is mainly related to centration. They used to say that corneal inlay are forgivable. So if it is slightly not in direction, it can forgive you. No, it's not right. It's up to zero point 0.2 milli. If you exceed that, patient is not happy. So you have to have an excellent centration for your inlay before you decide that this inlay is good or not. And I think that centration is the most probably. The patient is not going to have shadowing or light scatter, and even the focus will be excellent. Now, how to centralize an inlay? When we started first, they said just open a pocket like you do for LASIK, open a flap like you do the LASIK, and ask the patient to look at the microscope light. And that time you know where is the visual axis, and you just put it on the visual axis. Okay, so this is what we call internal reflection of light wave. We ask the patient to look at the light. But of course, this is wrong because first of all, we stop to do it under the flap. We have to do a pocket. The pocket has to be 250 minimum. There is no flap 250. So it has to be a pocket. And if you ask the patient to look into the pocket, look at the shape. Here we are. No. There is a film here. Okay. So this is the green light where you ask the patient to look at. Okay. Once you make the pocket, you don't see it. I'm sorry. Okay. Once you do the pocket, you don't see it. So the shape of the pocket, even if you put some BSS, if you clean the pocket, you can see it again. But once you put your spatula inside, you don't see it. So this internal reflection technique is not a good technique. The second technique is external, that you ask the patient and then you put your mark, which is also a very good technique. And then you can pass it direct to so everybody can say this is the best technique. You do the mark from outside and you put it inside. Yes, it is a good technique, but first of all, what about the angle kappa? Angle kappa is the distance between the center of the pupil and the visual axis, and this will mislead you. So the angle kappa will mislead you. This is the film. Now, what about the angle kappa? Angle kappa will mislead you because especially with high hyperobes, or especially with those with astigmatism, angle kappa is really huge, and this will give you misleading. Other thing, the visual parallax. If you compare your right hand and your left hand, your right eye and left eye, look at the patient and ask him to look at the light and make the mark using your right hand, and again, repeat the same process with your left eye, you will see that you have two marks and you can see it there. So if you use one eye each, so which one is right? This one or that one? This is your visual parallax, and this is also will make you in trouble. And then what about the size of the pupil and the position of the pupil? Sometimes the pupil is slightly not centered, and or maybe fully dilated, so you cannot rely on this technique. And this is the angle kappa, everybody knows that. And these are the two circles, these on your parallax, and this is if you rely on the angle kappa. And you see how big is it? How the distance here between the visual axis and the angle kappa. It is really huge distance. Now, the external technique, this is the technique I developed, which is so simple, so easy. You ask the patient to look at the light, and then you apply just PTK. And the PTK is only 20 microns. Why 20 microns? Just to leave a mark for you to see. and 20 micron to disappear by tomorrow. You are not taking the whole epithelium, you're just leaving a mark, 20 micron. So it's a PTK. What about the size? Here I put 3.8 because my inlay was 3.8. If you have an inlay which is 3.5, you can put 3.5. You have an inlay which is 4, you can put size 4. So you can decide the size. So it's only 20 micron and it's 38, and it is exactly on the visual axis because this is a PTK on the visual axis. You ask the patient to look at the visual axis. We can see that now you are applying, you are asking the patient, yes, on, please, video please, sir. Yes, you can see it's only just few shots, that's it. And when you take it, you can see the mark. And so it's external mark, but exactly on the visual axis. Now you are cleaning from inside. Still you can see the mark. And you can push your inlay to the exact position So as we said, PTK diameter adjustable, and that the circle clearly seen, and the PTK will disappear within 1 or 2 days. And this is the position. This is immediately after you place it. You can see the edges all around. Okay, so it's a simple technique, easy technique. Everybody can do it. And really, I made 77 inlays, corneal inlays. Before this technique, I removed 3. After this technique, I removed nothing. And if you look at the date, what time is it? What is it? 16? 18, 16. So how many years now? And they are still there. Okay? Thank you very much.
So good morning, everybody. Thank you for the invitation for this nice congress. I am from Morocco, and I'm so happy to be here to share with you my experience about the corneal modeling in keratoconus. So you know that keratoconus is a progressive corneal ectasia characterized by stromal thinning and protrusion, resulting in myopic shift and irregular astigmatism. So the problem is a reduction of visual acuity in quantity and quality, high order aberrations, spherical aberrations, and patient generally is intolerant to rigid contact lenses. So our mission is to reshape the cornea to regularize in order to reduce or even cancel the high order aberrations. So what are the means that restore the regular profile of the cornea? It's PRK or intracorneal rings. But what we will choose? We need decision elements. The first element that we need is the refraction. The refraction in keratoconus is very special. It's a crucial element. It's determined. We must determine the best correction visual acuity by 2 methods. The first method is the subjective refraction, autorefractometer based. So we have I think, okay. So the refraction is it's take time, and we must do some steps. First, we must change the sphere given by the refractometry automatic refractometry, and to have excuse me, donc to saturate the sphere, reduce the concave correction, or increase the convex correction. After the phase 3, vary the axis of the cylinder by successive rotation of 15 to 20 degree in both directions until an improvement in the visual acuity and above all the disappearance of the duplication, the diplopia. And after, we can change the cylinder in steps of 1 diopter as long as the visual acuity rises at the opticity becomes sharper than by 0.5 diopter. So I have here an example of automatic refractometry. The axis here in the right eye, we are at 20, and with this axis, this refraction, the visual acuity is bad. We are just we have we have a 310 for best correct visual acuity, and we have monodiplopia. But when we do these steps, when we do all these steps, the new refraction is just -2, and the new axis, it's 70 degrees, and the best correct visibility rises to 710. This axis, it's matched with the axis of the coma in the aberrometry. So refraction showed that visual deterioration is correlated with coma, so indication of aberrogated PRK, and not for topoguided PRK. The second subjective refraction, it's based on Fourier analysis in the anterior segment OCT CASIA 2 give this analysis of the axial map. So this is the four refractive maps, and we have the axis of the astigmatism. It's 132. With this refraction, we have just a 310 excuse me. Yes, we have 310 for the visual acuity, and with this axis. The Fourier analysis, it's give us, it send the astigmatism between the regular astigmatism and the axial asymmetry. We have two maps. So the axial asymmetry, we have another axis for the asymmetry, and when we adjust at this axis, the visual acuity arises. So subjective refraction now with the new axis, it's 110 given by the axis of the asymmetry of the axial map. The visual acuity, it's 810. So the refraction showed that by correcting the astigmatism on the axis of the axial asymmetry corresponding to the aberrometric coma and not on the axis of the regular astigmatism, the best correct visual acuity rises considerably, and the intracorneal rinsing will be centered on this axis for an optimal visual acuity results. Now, another decision, it's given by the tomography. It gives us the shape of the keratoconus, and we have three shapes who are simple shapes, and we have a good prognosis with the intracorneal rings. It's the nipple, the body, and the crescent shapes. We need just symmetric intracorneal rings. But if we have asymmetric shapes like a duck or snowman, this we need to have a good results. We need asymmetric intracorneal ring to correct this deformation of the cornea. So this we have a symmetric ring, and here we have an asymmetric ring with a different thickness along the ring. The thickness of the ring varies along its length. So the third element is the cornea OCT. We have the we can have a scare, so we have contraindication to do intracorneal ring. We have the map, the epi map of the cornea, and the map of the cornea. And aberrometry, very important element. We have the scotopic pupil adapted to optic zone treatment, a high order aberration, and we can choose PRK topo or aberrogated, and to integrate into the treatment plan. The treatment, if best corrected visuality is less than 510, we can do intracorneal rings. So we have now with this decision making. We start by PRK. PRK can be topography guided PRK. It's the Athens protocol. We know this. The Athens protocol plus than pachymetry must be plus than 450, maximum ablation of 50 to 60 micron, transepithelial PTK associated with simultaneous course linking, and we just plan for 70% of the refraction of for the patient. This protocol developed by Konopolis and by Kimonis has advantages. Its topographic PRK is reshaping the irregular cornea to a best fit spear, so it's logical. No need to remove cross-linked cornea. Less corneal haze and scarring. Cross-linking plus PRK in the same time have a synergic effect. Greater corneal flattening. Doing two procedures in one time is convenient and allows an immediate results. But we have some drawbacks. It's too invasive. We have two techniques, same setting, does not take into account the effects of cross-linking. Sometimes the effects of cross-linking is too much, does not address emetropia, so possible to do cornea ablation again, and the center is not treated, no compensation of the cyclotorsion or the shift of the center of the pupil, and treating anterior astigmatism can unmask posterior compensating astigmatism. But all these, the Konopolis and Kimonis show superiority of simultaneous treatment over sequential one in regards visual outcome and severity of postoperative haze formation. But Athens protocol cannot a full predictable refractive procedure. So we must inform the patient about the probable need of glasses of post-PRK. PRK, our experience, so we have the same results, good results. That is clinical case. It's a patient who we do intracorneal rings first because we have a Kmax at 1660. Donc rings first. The visual acuity after is this the map after rings, and the visual acuity comes to 710, and we have less astigmatism. The minimum pachymetry it's 461. So post-topo-guided PRK, we do a PRK topo-guided, and we have a very nice results. This is the differential map with the two techniques, intracorneal rings and PRK. Aberrogated PRK, it's transepithelial PRK. So we remove the epithelium by PTK, and after the aberrogated PRK, the platform allows us to choose which aberration to treat and to want or not the treatment of the sphere and the cylinder. So we have low tissue consumption, indicates even on thin corneas whose thickness is between 400 and 450. The low aberrations will be secondary corrected by glasses or by Visent eye-cell phakic implant. It's the movie. Okay. This is the two plan. So this patient has a coma. It's the big high order aberration. And have trefoil also, but it's coma. It's the big high order aberration which he has. So this is the Zernicke analysis, and we remove all aberrations that we not want to treat, and we keep just the coma aberration, vertical and horizontal coma to treat. This clinical with its topogated abrogated per K. Before we have RMS 1.19, and the image of the retina it's not good. We have coma. No, it's before. It's after. Excuse me. This is after. It's just 0.31. So after now, so it's before we have 3, and after we have 0.3. I finish now. The intracorneal rings, we have two rows for intracorneal rings to adapt the type of the rings to the cone form. To the asymmetric intracorneal rings for asymmetric shapes, we place the thick part of the ring in the mass curved area of the cornea. So to determine the second to determine the best correct visual acuity, and center the ring on the astigmatism axis. So here we have this patient. We have crescent shape. So we will place an intracorneal ring, symmetric intracorneal ring. We adjust by the axis at the asymmetric at the axial map. So we need one ring. That is another example. We need an asymmetric intracorneal ring because we have a duke shape. So we placed asymmetric ring. It's thick here and less thick here. So we placed the thick part on the steeper place, and here the one less thicker in the in the flattened zone. This is the results, and the visual acuity is very good after this, and it's the differential map. Okay, donc this map is for rings, and after we correct by ICL. This is the surgery. So the patient have rings, and we have important equivalent, spherical equivalent. So we do a ring with surgery with ICL, implant phakic ICL, and it's this result with the implant and the rings. So I conclude restore the corneal irregularity of the pupil entrance remains a real challenge. The advanced technology is able to read the highly aberrated corneas complicated topography shapes, and generate an adaptive profile treatments. Combined procedure adapted on a case basis, ensure good functional rehabilitation, namely gate per K intracorneal rings. Our patients are good example of combined surgery, intracorneal rings which regularize the cornea center with the reduction of high order aberration followed either by autoric ICL implants or myopia at implants corrects myopia. And the consequence regular astigmatism, or by PRK when the thickness of the cornea allows the refining the results of the intracorneal rings. Thank you for attention.
Right. I think few of our speakers are not here because of some reasons. One of them can't approach here because of fog on the way. So we are going to invite Dr. Hai next. He's going to talk about femto-based DALK.
Assalamu alaikum. I will talk about the lamellar grafts, the femto-assisted deep lamellar anterior lamellar keratoplasty. Bismillahirrahmanirrahim. Allahumma rabbi zidni ilma. I will skip the first few slides because they are just the theory that the definitions of the different types of keratoplasty, the keratoplasty types based on the replacement of the depth, including the different types of lamella, and talking about the deep lamellar keratoplasty, either manual like a big bubble or small bubble techniques done, and the femtolaser assisted deep lamellar keratoplasty. All the indications include this keratoconus mainly. The diseases which involve more than 90% of the anterior thickness of the cornea with normal endothelial and grossly normal Descemet's membrane, and some patients of high risk penetrating keratoplasties like atopic keratoconjunctivitis or superficial vascularization extra, because they got a very high risk of rejection in penetrating, then we can have this lamellar grafts to help to increase the visual acuity. The others like localized thinning or descemetocele, or after removal of the dermoids or the other tumors, the pterygium, all the smaller or irregular or freehand lamellar grafts may be helpful in restoring the thickness and the surface of the cornea. So talking about the femto laser, it is a neodymium glass laser of 1053 nanometer wavelength, and it can be used for giving incisions of precise diameter in patients undergoing penetrating keratoplasty, giving incisions of the precise diameter and depth in patients undergoing LASIK and deep lamellar keratoplasty, and even the incisions of the cataract and fragmentation of the cataractous nucleus before doing emulsification and phacoemulsification. That is what is femto assisted laser. So different uses of the femto laser. The different parts of the artificial interior chamber during the and after the COVID, we have been receiving, particularly due to some financial problems in Sri Lanka, we have been receiving eyeballs, and so using the eyeballs we do not actually need this artificial chamber. Otherwise, when we got a corneal button, we have to use this artificial chamber for cutting the donor cornea in cases of deep lamellar or the other corneas. So preparation of the patient and donor resection, then it could vary from the depth of 70 to 850 micrometers possible, adjustable pulse energy, and the special designed artificial anterior chambers are available in different designs of the penetrating keratoplasty. Different types of incisions, steps incisions could be given. Either it is round or oval resections, or the edge designs like standard cut we do, or the top head or mushroom types of shapes of the, or there is they are highly, when the incisions are like this, they are highly mechanically stable with the lesser degree of astigmatism. What is actually the purpose of my talk was actually the some practical difficulties which one may face, particularly our younger colleagues which are going to face doing a lamellar graft, which is assisted by the femtolaser. Just consider a patient of keratoconus in which we decided to go for a lamellar graft, and the thickness was around about 300 or something like this, and the thinnest part of the cornea had a maybe 200 or 180 microns in depth. And so what usually we do, I'll show you the procedure during while doing it, that while you do femtolaser keratoplasty, we have got an opportunity or facility to do a OCT of the cornea before actual resection of the corneal depth. So but while we are doing the section of the OCT which we are observing may not be in that part which is the thinnest at the time of the surgery, and we have to plan before actually doing surgery that how much of the depth of the cornea you have to remove while you're doing. Because when you do a femtolaser, and all you know, when you do a LASIK even, the cornea is applanated. It becomes flattened for a certain diameter, and only then the appropriate resection could be made, making flaps of the LASIK may be very thin until you make it flattened. You cannot have a uniform flap. And so this flattening of the cornea, when you are planning that you have to leave the thickness of the descemet's membrane and the endothelium, while you cut it, at the end you know that you have already cut that part also, which has got the thinnest part in the cornea, and there's going to be a perforation, and you will end up in converting the case into a penetrating keratoplasty. So it is extremely important, although it looks very easy. Those who are doing femto-LASIK or you are doing femtokeratoplasty, they can see that it is extremely easier to perform, to cut the donors and to cut the recipient while using this femtolaser. It is extremely good, and it gives you so regular edge of your wounds, edge of your grafts and also your recipients, that you can place the graft over and it fits in, and maybe sometimes you think that the fewer of the sutures may be sufficient, although you use a whole suturing of the graft, but it is so good. While you consider keratoplasty, it is not only to restore the transparency of the cornea and to improve the vision, but also to have a minimum astigmatism, which is very high in the patients of the penetrating or the lamellar grafts. It is because in manual grafts, you may have seen presentations or seen yourself while doing it. While you do a manual graft in lamellar grafts, what is there is that only that part of the interior stroma has got a regular or uniformly smooth edges, but the deeper area which you cut with your scissors is not that smooth, and at the end when you suture, this tags of the tissues which remains there, they do not allow the cornea to become approximated as uniformly as is in the femto assisted lamellar graft. I'm saying that it is the manual grafts are is anyway inferior to this, but doing this femtolaser assisted keratoplasty, this is very important to plan beforehand, preoperatively, that how much of the anterior part of the cornea you can remove. So when you have got the thinnest part, you must see which is the thinnest part on the tomography, and it should not exceed, it should always remain less than that while you are working. Even if you remove lesser part of the anterior cornea, and there is, if there is a 200 depth in the thinnest part, you may leave the 200 part of the deeper cornea there, so that you can replace the cornea with another 300. And the second important thing and the advantage of doing this is that the interface is very important in the lamellar graft. Until and unless your interface, your graft and the recipient are closely approximated, and there is no space in between while doing suturing, and the smoothness of your interface is very important, because even if the cornea remain transparent doing this recipient and the donor graft, but if the interface is not that smooth, although we are able to achieve smooth interface in cases of bin bubble technique or other manual techniques of deep lamellar near full thickness deep lamellar keratoplasty, but still the the interface which is there in cases of femto, because you can accurately, even up to the difference of 5 or 10 microns, you can have uniformly regular interface of both the cornea, the recipient and the donor. Let's see इससे वीडियो चलाना. So थोड़ा फास्ट फॉरवर्ड कर दो. Usually we decide how much the anterior part you have to remove and what remains there behind. It is decided at the end. Even if while we are doing perioperative, it is recommended to do pre-operative OCT of the cornea if you are doing it for the patients which are which are having corneal scars or corneal opacity, and you want to remove the interior corneal opacity up to the area where the cornea is transparent. Then you can measure the sizes of the opacity, the depth of the opacity, and at the time of the surgery you can confirm it. चल नहीं रही भाई? जी कितने मिनट की थी यार? आगे भी होगी वो एक दो पार्ट्स में थी. 5 मिनट की तो वो फिर चलने को. So इधर रोको, इधर रोको. So this is what is the perioperative OCT, and it is actually a donor cornea which was there in the MK fluid and become a little bit hydrated and become very thick. And what we do, we got a marker and we can measure the depth of the cornea you are cutting. And you know that from here to here it is about 400 or 500, or even, because sometimes the thickness of the donor cornea may be up to 800 due to the hydration of the donor cornea. So, and this is a little bit magnified, and this area will gives you the first. Actually, this marker goes up to this is the area of the endothelium with the rub, and when we can have this marker here to measure whole of the thickness, and then to see that how much it is hydrated. That means if you know that the central cornea is about 550 microns, and you are looking at this OCT that it is 800, that means it is almost about 33% thicker than the normal. And this marking of how much you want to cut will be keep in mind that how much it is hydrated. Because if you cut 400, it may remain after dehydrating to the normal transparency, it will become 350. So you have to have an increased thickness of the cornea, donor cornea, while you are cutting. The higher is the thickness of the cornea to be cut, the more more power of the femto laser is actually required. And also, if the whole of the cornea is transparent, lesser power is required. And if you have got a opacity in that area where there is opacity, femto laser will require more power to cut, otherwise that part will remain uncut. चलाओ जी, चला दें जरा. Okay, this is the measurement of the whole thickness from here yellow. Then we go up and see how much you have to resect. And because all of us are familiar with now the femto-assisted LASIK, it is similar to that. And the eyeball is got been for suction help and become immobilized, and then there are cuts which are given in the deeper part to separate the lamellar, and then there's the round cuts, and first there is the centration, and you know that you already marked the center of the cornea from here you have to cut, and this is the area where it is giving you that it is cutting is complete unless it goes there. Then once it is completed, the suction, and this is इधर जरा रोकना नहीं आगे जाएंगे. आगे जाएं थोड़ा सा, एंड पे जाते। सो दिस कितना रह गया, बस थोड़ा सा इधर हो गया। ये सक्शन हमने दिया, जस्ट रिमूव द सक्शन, and at the end what remains is that is all this disc of the anterior cornea is separated with a few bubbles, and then we have to एक और भी है इसमें आगे, थोड़ा सा और हो गया आगे। चलाएं। I just wanted to discuss few practical things, the practical hazards which we may come across while doing this femto-assisted laser, and not to do a very innocent types of mistakes which may end up in a disaster. So चला दो यार बस इसको, अब और नहीं है। This is actually the donor tissue cutting, and there was a video of removing the recipient as well. इसमें है कि डिलीट हो गया, अच्छा चलो नेक्स्ट करते हैं, ये नहीं है इसमें, ये ठीक है। See now to show you few of the snaps of during surgery, that पिछले वाले पे दिखाओ। Actually you can see that the cut is very round। किधर चले गए हो भाई, मैं कर रहा हूँ, सॉरी। Okay. So after cutting the
ये ले ले
recipient
पॉइंटर,
हैं?
ये पॉइंटर ले ले।
ये पॉइंट ले लो, ओके। कहाँ पे होगा यहाँ?
हाँ जी, यहाँ से
Okay,
नेक्स्ट
thank
कर
you.
लिया है।
Okay. Okay, you can see that how regular and I mean the cut is so smooth, and there are no tags which could be there while when you are doing the cutting of the deeper tissue by your scissors. And you just put a graft on it and you suture it, and this is up to the application of the 4 sutures. The lamellar graft, one must do a very tight suturing. The first 4 sutures should be very tight, and then you can apply continuous or interrupted suture as you like. And this is just to prevent the ingrowth of the epithelium in between the gaps of the sutures in between the two. So very tight sutures are required, and because patient is already keratoconus, in patients with keratoconus, there is a steep cornea, and while you are doing this steeper, their tighter suture, this is going to help in reducing the myopia, and if you are doing a good suturing, there will be less astigmatism as well. So these are few of the patients in which we have done this lamellar graft. This is an example of a very, different patient, which I did it with a lady. She underwent a cosmetic surgery for tonsils, and after 5 days, when they open up the sutures of the tonsils, there was a large ulceration with the deposits in the stroma, and very thin Descemet's membrane, a little bit of stroma there, with the vascularization and something like this. It was really, the surgeon was really surprised to see that while doing this tonsil, from where this ulcer and this has come. But at that time, what we did was to apply a very large conjunctival flap to help the patient to restore the thickness or to save the eye. After about 2 months, we just cut the upsize the conjunctival flap here to allow this all this conjunctiva to devascularize, to have less vascularization. And at the end, what we do was a combined, the femto-assisted lamellar keratoplasty. We did a manual resection of the anterior cornea in recipient, and then we cut a donor tissue with the femto, and we applied a little bit of the eccentric graft there. And this was a young lady doctor undergoing this cosmetic surgery and ending up with this. And this is just a combination of a femto laser assisted, donor cut, and the manually removed anterior stroma. and now she's happy to having a good cosmetic and also a useful vision. This is the last picture I took about 15 days after surgery, and the good cornea. It is really, I mean, very pleased to see that how much improvement, I mean, the God has helped us. Thank you, sir.
Okay, so we have, Dr. Noman is here. Dr. Noman, your talk is next, please. You're going to talk about refractive surprises in triple DMAC. Yeah? Thank you.
Assalamu alaikum. My name is Numan. I'm a cornea and tear segment surgeon at King's College London. Today I'm talking about refractive outcome of triple DMAC in Fuchs endothelial dystrophy. As you probably know, the DMAC surgery is that the DMAC graft includes only endothelial cells with decimate membrane, which is 10 micron thick structure. So I will start with the donor preparation. So at King's we prepare our donor cornea just before the surgery. We start in the periphery by doing DM scoring of the donor and dissection at the same time. And after that we make sure there are no micro tear 360 degree and it's completely dissected. Then after making sure of that, then we do the quadrant scuba stripping. We do that in all 4 quadrants, but we leave the central bit attached so we can do the trephination. So after having desired size trephination, then we do this triangle mark. This triangle mark gives us a hint about the direction of the DMAC graft, because it has to be endothelium down when it will be inside the eye. Then we do that final scuba stripping. So, and we will remove that 8 or 8.5 millimeter or desired size decimate membrane. So this is the host part. We do this patient had the cataract surgery and IOL, and then we do the DM scoring, and after scoring the DM 360 degree, we will remove that DM with the help of rake. So the decimate membrane will be completely removed in that localized area where we are going to place our graft. Then it's important to remove all the viscoelastics, especially from behind the lens. And then we lower the graft on guider and inject it in the anterior chamber. Once the graft is in the anterior chamber, we suture the main entry, and then after that we open the graft either with the help of tapping on the surface of the cornea, or the other force is we can shallow the anterior chamber. So once the graft is open and we make sure that the endothelium is down, then we do the max air fill. In this case we use SF6. We use 15% SF6, which is a non-expansile concentration. I know the posterior, my posterior segment guys, they use 20%, but that's expansile. And after after the maximum air fill, our preference is to get intraocular pressure above 60 millimeter of mercury for at least 10 minutes. And after 10 minutes, we remove some of the air and just leave like 60 to 70% of the air in the anterior chamber, air or gas. At King's, we usually use air, but I have also used SF6, 15% SF6. So after that, after we examine the patient after 2 hours, we check the status of the graft and the depth of the anterior chamber, and check the intraocular pressure. If the pressure is below 20 millimeter of mercury, then we let the patient to go home. And we see the patient next week, and we keep the patient on intensive dexamethasone, preservative-free, and chlorphenicol. So we did a small study where we included 21 eyes who underwent triple DMAC, which is basically simple cataract surgery plus IOL plus DMAC. And the objective was to determine the factors for the poor refractive outcome in those patients. as we know that there is usually a hyperopic surprise in DSEC of around 0.75 to around 1.25, but there's also hyperopic surprise in DMAC. So we analyzed our data. So it suggested that there was significant improvement in the visual acuity at 6 months as compared to the preoperative. This is log mark, so that's why it's going down, but it's getting better. So in Snellen, it's most of our patients had visual acuity 6.9 or better than 6.9. There was significant improvement in the CCT preoperatively in 6 months. But this was the interesting part. Most of the patients had refractive surprise of plus 0.5 diopter. We aimed for minus 0.5, but still patient had a refractive error of plus 0.5. Then this is a nice, it's a bell-shaped and normally distributed data, which means that it's not skewed, so it's a good data. This presentation of bar chart. We then we analyzed the Q value of the back of the cornea by a sham flock technology. We can use a pentacam preferably, or we can use Galilei scan. We use a pentacam, and we checked the Q value of the back, and we did a simple scattered dot plot, which shows that there is some correlation between Q value back and the refractive surprise. If all these dots are more or less like in a line, it means there is some correlation. Then we ran Pearson correlation. So Pearson correlation, we had the Pearson correlation of about 0.703, which means that it's extremely significant, which actually means that it has direct or positive, very strong correlation. It means that if someone has high power of Q value of back, then we can predict that patient will have high hyperopic surprise. But what is Q value? So, like I said, that we can get the Q value on pentacam or Galilei scan. It's a quantified indicator of aspherical degree. The normal Q value is about minus 0.26, which basically means that the cornea is a prolar shape, which is steeper in the center as compared to the periphery. But if the Q value is equal to 0, it means that the steepness of the cornea is equal in the periphery and the center, and the cornea is a spherical shape. But if the cornea is oblate shape, it means that the cornea is steep in the periphery as compared to center. That's what happens when the patient has myopic classic. Then if you look at the Q value after myopic classic, patient will have a plus Q value. In Fuchs endothelial dystrophy, the corneal edema starts in the center. It doesn't do anything to the front part of the cornea, but it pushes the back layer of the cornea. It changes the Q value from negative to positive. If someone has a positive Q value, it means that that patient has more prone to get hyperopic surprise. So our results were that there was hyperopic shift of 0.56 diopter, which was directly related to preoperative Q value. So we did some literature search, and then we had more or less like similar results in different studies. We also realized that there was another factor, what was CCT, central corneal thickness, which was also directly related to the hyperopic surprise. If someone has higher CCT, like more than 600 micron, that patient is more prone to have hyperopic surprise. So we did some literature search, and our results were also in agreement with this study. So is there any accurate formula which can predict with the 100% certainty that what kind of hyperopic surprise patient will have after the cataract surgery? Answer is simply no, because for example, in patient with the cataract, in keratoconus, if you are planning to do a cataract surgery, the most accurate formula nowadays is the 4th generation Kane formula, K-A-N-E, Kane formula is the most accurate formula to calculate the IOL. And for example, patient had with the LASIK, the most accurate formula is online ASCRS formula. But is there any formula for the Fuchs endothelial dystrophy you are going to have triple DMAC? Answer at the moment is simply no. But there's a study which suggested that when it comes to the third generation formulas like SRKT and Haig's formula, SRKT is slightly better. It's not 100% correct, but slightly better than the Haig cell formula. So take-home message is DMAC causes a significant change in corneal central corneal thickness and the curvature of the cornea, especially the posterior curvature of the cornea. That should be taken into account while operatively while calculating the intraocular lens before the surgery to minimize the risk of hyperopic surprise. These are my mentors. Well, thank you very much. Yes, so there are two techniques. Either we can put F stamp or S stamp or C stamp, or we can do a triangle mark. What we do, we create a half. That was actually cutting. So we cut the half of the triangle. So the first cut has to be 100% 90 degree. The second has to be that some angled, so we can oblique or angled, so we can judge that this is a triangle when the graft will be inside the eye.
So when your endothelium is down, it should be on the other side.
Yeah, that's correct. That's correct. When we prepare the donor tissue, the direction of the triangle is clockwise. And when this is inside the eye, it should be anti-clockwise.
There was a very interesting case provided by one of our colleagues. That patient had DMAC and underwent LASIK after DMAC
After DMAC.
or before DMAC. So both anterior and posterior surface were changed. And then he developed cataract.
Good.
So the idea, what lens to put? The regular formula gave us a number, which was 22, something like that.
Yeah.
And then they rely on the other formulae, which you mentioned. They suggested 25. But when he took the formula that he took it from the Galilei, as you mentioned, which counted the new anterior power, as well as a new posterior. So there are two news, not only a new anterior or
Yeah.
new posterior. There are two new surfaces. So he counted the new powers from the Galilei. Now he can get the real power. It was much higher than that. It was 27 or 28. So there was really a surprise. And then he looked at the periphery for the Q value.
Yeah.
And after he measured the Q value, whether it is plus or minus, he decided the type of the lens, because you may have lenses which are aspheric, you have the lenses which have minus Q value, and you have some lenses with plus Q value. So he compensated the Q value by the type of the lens, and he compensated the error by the number given. And he did not do that. He did the one on the formula you gave, and it gave exactly the 3 diopters difference. So he has to remove the lens, and he has to go back to the formula of the anterior, posterior, and the Q value, which is the simple thing, but he never thought about that. So this was an excellent idea. And just to make Q value easier, because a lot of our people, you just mentioned Q value. Q value is the change in the periphery. Normal cornea is not sphere, because if normal cornea is sphere, the light in the center will reach the retina, but the light in the periphery will be convexed more, and it will be scattered. The image will be scattered from the retina forward. But God did not make it like that. God make it, it's not, from the very center, it goes slightly flatter. So the light goes slightly down, so all the lights from all directions, they meet at the retina. If they are in front, it is positive aberration, spherical aberration. And if it is behind, it is negative. So many people, they say Q value is minus, and it gives spherical. How is that? It is so simple. Minus means that this is the cornea. If the cornea increases, so Q value is plus. If the cornea is flattened, the Q value is minus. So the Q value plus and minus is the shape, okay? While in all direction it gives a plus because it's in front of the retina. The normal cornea, it gives a plus. But if you add the lens under the cornea, both together give it down to the retina. Okay? So normal cornea has negative Q value, but positive asphericity. So when we say reduce positive asphericity or increase positive asphericity, because we go in this direction. Is that clear? Just to make it simple. Thank you.
Thank you very much.
Thank you. Dr. Shahid Mirza will be the next presenter. He will talk about steps to successful keratoplasty.
Assalamu alaikum. I'm Professor Shahid Mirza, working at Karachi, and I'm doing cornea at Gumbert since 2000. So I discussed the steps of successful step and tips of successful keratoplasty. The things, the trends has been changed from keratoplasty. The keratoplasty full thickness from up to the layer wise and up to the capro. So first the keratoplasty started in journey is more than 117 years. So it first is done in UK. Sorry. So this done in the UK, then trend change in the square form in 60s, then in central fixation and all one fitting in they modify. Then again the keratoplasty modify into 5 different full thickness to DELG, DSEC, DMAC and capros. So these trend has been changed right now in world. In USA the trend of full PK is less and EK are more. In our what is a definition of successful PK? So it's a clear, compact, thin graft, improved VA, 2 or more line, and astigmatism less than 3 diopters. So the key point of the successful, the donor corneal selections, pre-operatively planning, surgical techniques for donor as well as recipient, and intraoperatively complication. If you all combine these 4 or 5 things, so you get the good results. So you cannot get the more surprises if you consider all these things. So the most common indications in world trend is optical or therapeutical or redos in worldwide. So in USA trend is different, India is different, and we have also difference because we have going for therapeutic, or they mostly we do post-herpetics, failure graft, and optical for correction for keratoconus. So these are we are here sees more post-fungals. These are the, if you choose the good cases, you get the good results. So you have to be very careful about those who are doing young surgeons, so should be select very good cases if they want to be a success. So should these complications are the contraindicated for a new one, or these are the very complicated, these for the capros, not for penetrating keratoplasties. So these are the contraindications you not do in following circumstances if the active inflammations. You have active inflammation, ocular surface diseases, uncontrolled glaucoma, or previous failed rejections. These are the patients you cannot choose in those who are doing in the earlier cases. Now, the very important thing, the donor cornea selections. The cornea donor selections, you should be the patient corneal graft of the donor. The age is very important. It should be more than 15 and less than 65 because the cornea is stabilized. Death, date of death again is very important. If the cornea is fresh, the results are very good compared to if you long preservatives. The fresh cornea is very good. Fresh tissue has very good results. So it should be, the time should be very properly mentioned. The recommended who take the donor tissue should be the not prolonged death time less than 20 hours. And blood cell counts again very important. Is more than 2,500 microns and clear zone. These should be very clear. These are the solutions which can use in these days for weekly, for 10 days, for 24 days. So test should be performed. If the graft is good, the patient selection is good, the results are good. And evaluation of a donor, you have all the history points and slit lamp examination. Prior to this is come in the USA based the tissue supply agencies and the Sri Lankan, they provide this media to, you can check the current condition of your tissue. This is speculometry. So the preoperative planning again is very important. It's very important because you know the patient anesthesia, how you manage if it's opaque media, you're doing failed PRK, or how you perform the PRK, how you trephine. You trephine interiorly or at the margins, because some surgeons prefer at the margin because they redo very clearly and they get very good results after you give the incision on the same marks. And if you plan for DSAC or DMAC or you Kepro, so it depends which type of patient you deal. So anesthesia is again very important, and akinesia. So the most of surgeons here, some do in a GA, some do in a local. So you should be keep in mind the good anesthesia is one of the key factors for your success, and you should be keep again in GA you have most complication occur in GA, the retrobulbar hemorrhages. So these are the points you should be keep in your mind to how you get the good anesthesia and good akinesia, so your patient is comfort, your results are very good. So if you do the patients and redo what you suggest the procedure, you assess by the patients. This is again because the patient has high expectation, and you should be explained prior to what's your prior visual acuity or what you do, what you want. So anesthesia, the possible anesthesia complication of PKs are sometimes globe perforation, intraocular injections, retro. These are the complications you should be keep because those who are given local anesthesia. So maybe sometimes the puncture of the optic nerve, if there is anesthesia, you stuck in a local anesthesia, the whole procedure is stuck there. You cannot do the go further. So anesthesia or PK, you should know the patient unstable, mentally weak, or young female. You have no choice. You not go for a local. You go for a GA. So these are the very important point you should be consider again. Then surgical planning, anesthesia. If you have medias opaque, you think about the management of how you manage. If you fail PK, repeated trephine, you want to do repeated trephine, you want to dissect on the same area, or what you choose. I think this slide is again repeatedly. So if the opaque media, might be you have a cataract, what you do? You should remove this one, and again you have a backup of hard lens, and you should take the biometry. You don't have a biometry, but take keratometry as a 45-40 you have universal principle and a hard PMA lens, or you have a Alcon CT lens you have. If these are the steps you should be consider in every case, because you flinga rings, marking is very essential. You don't know after the open sky, maybe the tissues adhere with the underlying structure or attach with the lens or maybe a dense cataract. So when you trephination, it's very helpful as marking and this flingering. So the cataract is come up, sometimes you get surprises, you don't know what's happened, but it will help you a lot. These point, if you keep in your mind, should be get you good results. These again, you have a backlog, you have a different IULs, IULs, what switchers, and you should have plan for how you manage the cataract. So flingerings is also helpful if you do aphakic, aphakic and AC implants, IOL. So it hold the eye and it's helpful for you. And surgical technique, as again you consider surgical techniques for recipient, preparations of recipient eye preparation. You should keep, again, the flingerings should be, you use flingering because of if you have patient is young or cataract or aphakic, you should measure the corneal diameter for successful mark the center, because if your cornea center, you have good optical area, you will get the good results. Dimension of diameter of donor size, and you should go prepare the donor first, then you go for recipient, because you don't know if the pressure is raised and sometimes it's come up, you cannot hurry up and do simultaneously. You have preparation, not your donors, the graft is not prepared, and you go for this, so it's sometimes creating mess. And usually we 8.8 to 8.5 size is usually we taken for the donor's graft. I mark the suture area because it's very helpful in suturing. So the flingerings, so you measure in vertical and horizontal for periphery, then you mark the center, then you mark on the cornea for it's helpful, then your trephination with section trephination, it's very helpful. You prepare the donor one. So open sky is give you flingering in these cases is very helpful. Yamani, you can do Yamani techniques, you can do open sky technique. So you remove the lens. So intraocular complication, when you perform the surgery, again, you have you can get surprised in anesthesia, improper trephination, you might be bleeding, misalignment, iris lens damage, capsule damage, expulsive hemorrhage. These can be done in surgery. You should be keep in your mind these points. The perforation can be done by needle or episcleral or rotational compact. It can be so you avoid these all complications with you use the spatula needle, not the pointed needle. So if you want to good trephination, you get good instrument. These are right now they're easily available of suctions trephination for donor and as well as recipient. So it's very helpful and very stable, and you will not damage the underlying tissue. So again, you avoid the misalignment. You can use the flingering and mark the cornea, and then you plan and suturing. You help in suturing technique. So it will very helpful in suturing, because if you mark prior the cornea, it will very helpful in suturing, and it's properly aligned and no tension. So one of the factor of this type of post-herpetic or this vascularized cornea, if you get this type of cornea, you should remove this vascularization done by peritomy and cautery, and then you do, but this is a high risk factor. Avoid the damage because you put the heel on, and if it is damaged, you repair. You should keep in mind that this is one of the worst type of, and capsule also, and avoid the rupturing of the capsule. So you have a backup of help of vitrectomy and IOLs and meiosis. It will less chances to rupture the PC. Suprachoroidal hemorrhage is one of the complications if you go for a general anesthesia, or sometime if you have not properly anesthesia, this occur in the ocular factors and systemic factors. So the list of 6 should be this, keep in this suprachoroidal hemorrhage, and it get you intraoperatively vitreous loss and suddenly decompensation movements, they come up, and these are the risk factors intraoperatively. One thing you keep in mind, the several ocular cases of hemorrhage have been reported when the keratoplasty is performed under the general anesthesia. So as in buckling and endotracheal tubing. So lens management, accordingly, these are the points you should be, you choose a good case, donor as less than 65, endothelial good count, preoperative planning, general good anesthesia. If you go local and general anesthesia, surgical technique, you have good planning, good assessment, post-operative complications or intraoperative complications, you should be keep in mind your intraoperative complication, and end of the surgery, you not CDL test and wound should be properly approximated, and you should be given last subconjunctival gentamicin, you should not be given. Thank you very much for your listening.
Thank you, Dr. Shahid. If there are any questions, I think we don't have other speakers. We don't even have time. Any questions, please? Yeah, sure.
My question is from Professor Abdul Hai. Sir, first of all, thank you very much for presenting such amazing cases. Now, sir, did you encounter the problem of haze after femto-assisted DALC, especially the interface haze?
Yeah, I've been doing this manual the lamellar keratoplasty for so many years before actually the femto was available. But what I believe is that the haze is less in these cases and when we use femto laser. But still, it actually depends on multiple factors. It is not only the effects of the femto, but as far as once you have got a very smooth surface on the recipient cornea and the donor cornea, the part, the haze and the irregularities of the face are less, and this is what is important for the final outcome of the visual acuity. So I have not actually noted the number of times I've got a haze. I cannot give you the statics, but what I felt was that in femto these haze and the edema or it is rather lesser than the manual types.
Any more questions? Yes, sure.
You use a femtosecond laser to do the cut of the cornea, and it's a plano. We have a planation with and we have a plano section. So there is a risk to have a different thickness of the cornea, cutting cornea. You haven't an experience. I have experience with the Visumax femto laser, and for the Visumax, the specificity as the cornea, the cone is curved and on the cornea, and the cut is follow the curvature of the cornea. So we have least risk to
Actually,
have
thank
a
you for
perforation.
asking this question. This is what I emphasized in my talk, that as this is applanated, the surface become very, straight and flat, and so the cutting is uniform. But doing this cutting, we have to keep in mind the thinnest part of particularly those patients which are keratoconus, and they have got a very variable thickness on all of its central cornea. So the thinnest part, the thickness of at the area of the thinnest part of the cornea must be noted pre-operatively. And if we know that it is only 200 microns, so that means if we remove the 200 microns of the anterior cornea, we are going to remove whole of the cornea in that part which was the thinnest. So what we have to do is that we have to keep in mind that we should not, it should always less than the thinnest part. The anterior part removed should be less than the thinnest part of the cornea. Only then you can, avoid perforation while doing this. Once in my initial cases, when it was not in my mind, I had got a very micro perforation, although I was able to manage it. Doing this lamellar by putting a lot of viscoelastic and then and suturing the cornea very tightly, and putting a little bit of the air to press it. So it was all right, maybe a little bit of edema in the first 2 weeks, but there is always a chance of having a larger perforation if you do not keep in mind. But as you know, the more steeper cornea in keratoconus, it is thinner and it becomes very flat while you are cutting. There is a lot of suction in the machine. It is not going to move the eye, and then you applanate it to the extent that you can see on OCT that it is all very flat. So it is the curvature is all abolished. It is all, while you are cutting, it is very flat. So the rounded corneas, the cornea is only cut good if it is flat. Otherwise, if the femto is going to cut a rounded cornea, it's going to end up in any, some area it may be cut through 200 and sometimes it may be cut 400. So in femto, it is not that, it is the flatter cornea which is cut. Thank you.
If you have any scare in the cornea, it's contraindication to use the femtosecond laser. If you have scar, opacity here.
Again, this is a very important and part of it. Whenever we see the scars, particularly in patients of keratoconus, what most of the cornea people who are not doing femto, they considered it is difficult to perform a deep lamellar keratoplasty, and we considered going for a penetrating keratoplasty. Even if your scar is a little bit there up to the Descemet's membrane, it is recommended to do a lamellar graft, because all the penetrating graft going to be rejected maybe in 5 years, 10 years, 15 years. I've seen few cases which are for the last 40 years they are there, but the lamellar grafts, once they are successful, they are going to remain there for the rest of the life, like the other eye. So even if very small scars remains there in the endothelium or in the Descemet, they are going to minimally affect the vision, because they are very thin and they are placed in the deeper part of the cornea. And the presence of the scar is not at all a contraindication for lamellar, and it is not at all an indication for penetrating keratoplasty. One must go for lamellar graft. One of my patients, which I have shown you the picture, it was a young girl who had a anterior lamellar corneal opacity, and the deeper area was good, and what I did was a lamellar graft. Thank you.
Thank you. I think we are going to wrap up here. Thank you to all the speakers. Good talks, good knowledge. Hopefully we'll learn from each other and continue to do that. Thank you, inshallah. Thank you. Thank you. It's lunchtime now, so everybody should be hungry now.